Hi, good morning, everyone, and welcome to, of course, this 2021 annual National Minority Equality Forum. I'm very excited to be joining you as moderator for this esteemed panel. My name is Mia Keeys, and I joined as the Director of Health Equity Policy and Advocacy with the American Medical Association Center for Health Equity. But always, I am also just joining as an incredible fan of the NMQF and of all that they do. Through this annual summit, and especially as it pertains to what's going on right now, but then overall with respect to how NMQF works with the Congressional Black Caucus Health Braintrust, I trust that all who are in attendance today and tomorrow, you will glean quite a lot from the numerous panels. And speaking of which, our panelists today couldn't bring more insight with respect to the critical conversation around minority health or minoritized health, especially at the juncture of geography and coronavirus. So today we're joined by 4 esteemed panelists who will help us to discuss what's known as the Minority and Rural Coronavirus Insights Study. And without further ado, I'm going to go ahead and just give you brief introductions to our panelists. We have joining us today, Mr. Carl Garrett, and unfortunately, Carl's camera is not going to start, but I promise you the words that you will be able to hear from him, you'll be able to hold on to those. So Carl, even though we can't see you in person, we appreciate you and look forward to you uplifting the Centene Corporation's conversation and history about how you all came to join this partnership. And Carl joins us as the Senior Director of Government Relations for Centene. We also have with us NMQF's own Vice President of Clinical and Social Research and Development, a good friend of mine and someone who I admire quite a lot and in a deep way, Dr. LaTasha Lee. Dr. Lee, we're really excited for you to be joining us today. And I know that you'll be telling us a bit about how you've been coordinating this study on behalf of NMQF and working with our on-site in the field investigators. Speaking of which, we also have with us Dr. Marian Sampson, who serves as the Chief Medical Officer at Osceola Community Health Services, which is an FQHC in Florida. And Dr. Sampson will tell us a bit more about her role with the study there. And then finally, we have joining us Dr. Garrett Wiltz, who serves as the Chief Executive Officer, as well as the Clinical CHO at Teche Action Clinic, which is also an FQHC based in Louisiana. So welcome to our panelists, welcome to our audience members. Before we get into our conversation, I just want to remind everyone, if you have questions, and I certainly hope that you do, please put your questions in the Q&A box below, right? So put your questions in the Q&A box below. But if you have just any time to chat, or if there's conversation that you'd like to elevate, put your comments in the chat box on the side. Questions below, comments on the side, okay? I wouldn't be able to see the questions otherwise. All right, so let's go ahead and jump right into it. What I'm hopeful that we can do is hear directly from our panelists, and I'm going to pass the microphone to Carl as he's going to give us just a bit of a background about the actual partnership for the Minority and Rural Coronavirus Insights Study. So Carl, please take it away. It's so good to have you here. And now we can see him, so that's fantastic. As his audio is getting connected, we're going to go ahead and actually give him a little bit of time to get situated. In fact, I'm going to ask Dr. Lee to just tell us a little bit about the NMQF's role with respect to the study, and then we'll go ahead and come back to Carl so he can give us a bit more background as well. LaTasha?
Great, thank you. Yeah, just nod if you can see my slide. The Minority and Rural Coronavirus Insight Study was an incredible effort by NMQF and Centene. And I believe Carl has audio now, so he was going to kick things off. Carl, are you there?
Perfect.
Yeah. Can you?
Let's do it. We can hear you, Carl. We're all set. And then we'll come back to Dr. Lee.
Okay, thank you. So I don't know if you can hear me or see me. I'm here. Anyway, my name is Carl Garrett, and I work as a Senior Director of Government Relations at Centene Corporation. I'll really be focusing my remarks on Centene's role in the Minority and Rural Coronavirus Impact Study. Before I go into Centene's role, let me first provide a quick introduction of who we are. We are a leader in the government-sponsored healthcare space. We have a growing presence in Medicare. We're the largest Medicaid and marketplace company by membership, and we serve TRICARE members. While Centene is national in scope, We believe quality healthcare is best delivered locally. Now, we all know the national COVID-19 story disproportionately impacted communities of color. And if we remember back, a year ago, March, April, May of 2020, we had the hard-hit areas like Illinois, New York, Louisiana, Michigan, and Ohio, with very high mortality rates, especially among communities of color. Now, let's look at Centene's response to COVID-19. Our thinking was, how can we help communities in need cope with the pandemic? And really, our efforts included sourcing and distributing millions of pieces of PPE, partnering with Samsung to expand access to telehealth in underserved communities, as well as working with partners to mitigate the impact of social isolation among kids. In addition, health equity is a core focus area of Centene, as well as our purpose is to transform the health of the community one person at a time. And we thought, what more could we do? And really, we thought, what about a research study? An initiative focused on examining the impact of COVID-19 on communities of color and other underrepresented populations, groups historically that have been underrepresented in research, as we all know. So how could we bring this study to life? Really, it's through the power of partnerships. At the national level, we had a trusted national partner in the National Minority Quality Forum and its partners. At a second level, we had the federally qualified health centers, which were selected because of their longstanding relationships, experience, and trust earned in meeting the health needs of communities of color. And we also partnered with Centene's local health plans as well. We had a couple of operating principles around this effort. One, that the community events were free and open to not only Centene members, but also to non-Centene members, very important. And secondly, it was important that there was a research component to this at the back end with NMQF and other entities. And what I've just described is the context for this particular effort. I will now turn it back over to my colleague, LaTasha Lee, to kick us off. So thanks again, and apologies, everyone, regarding my video. Tasha?
Thank you, Carl, for those remarks and for Centene's commitment to addressing the impact of COVID-19 in our communities. So I'm going to share my screen again. So the Minority and Rural Coronavirus Insights Study, or MRCIS, was a study that we launched late last year. And we are so excited to give you a bit of a snapshot of what's going on. So starting with a bit of background and history. So we know that COVID-19 has disproportionately impacted communities of color, not only in the number of cases, but also hospitalization and death. And so on this slide, sources CDC, we see the racial and ethnic minorities that have truly been impacted by this particular pandemic, where you see that communities of color have an upwards of nearly 3 times the number of cases, nearly 5.5 times the number of hospitalizations, and nearly 2 times the numbers of death. There are a lot of factors that are postulated to really impact the spread of the virus and individual risks, but the true answers aren't known. And so while we know that race and ethnicity are often related to underlying health issues in our communities, things such as socioeconomic status, social determinants of health, access to healthcare, and increased exposure, we truly wanted to delve into this a little bit more. We know that where you live really matters. And so on this slide, I delved into those numbers a little bit closely. So in Louisiana, African Americans represent about 70% of the dead from COVID-19, but only 32% of Louisiana's population. In Illinois, African American death rate was 6 times higher than that of white residents in Chicago. In California, statewide, Latinos make up 40% of the overall population, but account for 61% of California's coronavirus cases, and as well as 50% of deaths from COVID-19. And in Florida, while African Americans account for 17% of the Florida population, they account for 21% of COVID-19 deaths statewide. Comparatively, non-white Hispanics comprise 54% and account for 47% of deaths. And lastly, in Ohio, 14% of the state's population is Black, but 25% of COVID cases, 32% of hospitalizations, and 19% of COVID deaths are among Black Ohioans. So as Carl indicated, Centene, NMQF, and our sponsors with Quest, or our sponsors at Quest, led this effort to really understand the impact in communities of color. So the Minority and Rural Coronavirus Insights Study is a prospective 5-year longitudinal study The testing and research initiative is led by NMQF in partnership with our FQHCs, who you'll hear from a little later, and other community agencies. And then the research component is conducted by NMQF, Quest, and our partnering labs. Right now, our initial research focus is primarily on communities of color. So these are our 5 FQHCs across the nation. So in Illinois, we have Aunt Martha's Health and Wellness. In Ohio, Primary One Health. In Louisiana, Teche Action Clinic. In Florida, Osceola Community Health Services. And in California, John Wesley Community Health. So we'll hear from 2 of our FQHC partners on this panel today. So our testing strategy involves enrolling 5,000 individuals who are being tested at these FQHCs for COVID-19. So we're utilizing these tests for both clinical and research purposes. And while we anticipate 5,000, we may end up oversampling over the course of the 5 years. We have viral testing, that's PCR nasal swabs that Quest has donated for this initiative. But we also are doing antibody testing. We want to know whether an individual does have antibodies to the SARS-CoV-2 virus. And we are doing antibody testing from 2 different labs, and we'll have 3 major antibody tests as part of this effort. We also have additional labs that are donated by our partners at Quest. And these include labs such as CBC, complete metabolic panels, complete lipid panels, hemoglobin A1C, C-reactive proteins, vitamin D, and other labs which we think are predictive to disease severity. And lastly, each study participant has whole blood and serum samples that are aliquoted and stored in our biorepository for future genomic, proteomic, and metabolomic studies. So with that, I want to give you a brief snapshot. So we have nearly 4,000 individuals enrolled into the study thus far. The majority of our population represent the Hispanic Latinx population, with 49.8% of our overall study population, 25.1% Black African Americans, 21% white. And then we also have Native American populations, Asian and Native Hawaiian, other Pacific Islander, and then some individuals, due to their preference, preferred not to answer this question, around 1% of our study cohort. So as usual, when you're talking about clinical studies, it's really important to look at gender and age. And while in clinical trials, you usually see a large percentage of white males, we actually have less percentage of males and more consideration of females in our population, with 61% of our study population being female and 39% being male. Additionally, the majority of our study population tends to be over the age of 55. So let's jump into some just high-level results. So when you talk about SARS-CoV-2 molecular testing, we're talking about the nasal swabs that so many of us have experienced during this pandemic. And so NAT-based testing, or nucleic acid amplification testing, or PCR testing, tells if an individual has active infection with the SARS-CoV-2 virus, the virus that causes COVID-19. In our study, we see a positivity rate of 10.2%. Then if we look by site, the site with the highest positivity is our site in Illinois, Aunt Martha's, with 23.16%, followed by Ohio, which is our site in the Columbus area, with 9.05%, and then Louisiana, and you'll hear from Dr. Wiltz today, at 6.65%, followed by Florida and California. We also are testing individuals for antibody presence, and we have nearly a quarter of our study cohort who have some antibodies to the SARS-CoV-2 virus at 24.5%. So this study is, as I said, longitudinal, and we do plan a lot of ancillary studies, many of which are beginning to go underway, including our antibody testing study, and future efforts will look at antibody quantity testing, really to look at the impact that either natural immunity and or vaccination has in the study population over the course of the study. There are also behavioral health arms, coronavirus and cardiovascular studies, diabetes and coronavirus studies, as well as genomic studies, which we really want to understand the underlying genetic factors which may be driving differential disease outcomes in these racial and ethnic minorities. So that was just a brief snapshot, and I'm looking forward to discussion. But I really want to thank our sponsors, NMQF, Centene Corporation, Quest Diagnostics, as well as our FQHC partners at Osceola Community Health Services, Teche Action Clinic, JWCH, which is John Wesley Health Centers out in California, Aunt Martha's, and Primary One Health. And of course, our amazing group of study participants representing a large number of minority communities. Thank you.
Dr. Lee, thank you so much for laying out the, just the overall purpose of the study and the breadth and information so far that you all have available and are making available to the public. And Carl, thank you very much for laying it out for Dr. Lee to take the time. I want to now move over and ask Dr. Wiltz to give us a bit of insight regarding Teche Action Clinic's relationship with the communities in Louisiana. And then we're going to ask Dr. Sampson to give us a bit of the same from the Florida perspective at Osceola Community Health Services. Dr. Wiltz.
Well, good morning, and it's a pleasure to be here with all of you and those out in the audience. Just a little background, and I think she'll put the slides up. The first slide, you can go to the next one. Just to give you an idea, first of all, Teche Action Clinic has the distinction of being Louisiana's first community health center. We were established in 1974 with a migrant seasonal grant to take care of the seasonal sugarcane workers in the community. And then we've evolved over time. And if you fast forward, now we've been around 47 years. We have 16 locations in 7 parishes that are illustrated on the map of Louisiana. For those of you who don't know, we don't have counties. We're a little bit different in Louisiana. As always, we have parishes. So if you look at the service area map there in the darker gray with the dots, that represents all of our clinics. Next slide. So this is St. Mary Parish. What we did early on was to hone in one parish. With 1,000 tests to be performed, we felt it would be delusional if we went to all 7 parishes and did it piece by piece. So what we did was concentrate on St. Mary Parish. And if you see the map of St. Mary Parish right there, every parish that we're located in, we have a presence in the east or west, so we cover the whole parish service area wise. The dots on there represent how we laid this study out. So we had 1,000 tests to perform. And one of the lessons learned, and I attribute it to the fact that Teche Clinic in particular, we had a history of doing research-oriented projects with the NIH. So we have done some, particularly with the PCORI type of basis, the patient-centered outcomes research. We had done studies on cancer, HPV vaccinations, obesity, diabetes, hypertension, and have been published historic for the last, I guess, 25 years or so. So our population were used to being asked to be in studies. The way we set this one up, and the map is important because we started testing the patients within our system. So we scheduled them. As I tell folks, FQHCs are ideally suited to be participants in clinical studies, because if you're looking for a certain population, we can run reports in our EHR and tell you demographically. If you're looking to study African-American females from age 30 to 54, we can run reports and tell you what that total population is. And we can do that for just about every demographic that you could imagine. So what we did was, when we started the study, we scheduled our patients who are already coming into us on an ongoing basis in our Franklin and in our Morgan City clinic. So the study was open to them the whole month, and I think actually about 5 weeks. So we built that into the study itself. To cover the whole parish, we have a mobile unit, and we took our mobile unit. In the first 2 weeks of the study, we had it located at the Franklin Recreational Center. So if you can imagine, we were having people coming in on a daily basis at our clinics. At the same time, we had the mobile unit set up at the community center for community testing. And then after 2 weeks, we moved our mobile unit to Patterson, which was in the central location of the parish, for a week at City Hall. And then for the last 2 weeks, we moved the mobile unit to Morgan City. at the Osceola St. Mary Hospital and Medical Office Complex. So if you go to the next slide. So this is what we wound up doing. We wound up enrolling, it took us a little over a month to do it. But again, the best laid plans, if you have a plan and operating on a schedule and the trust of the community, is why we were able to achieve such, I think, early success. To be reflective and to be intentional, because African Americans were and are affected more than any other population. We were very intentional. All the way to extreme right is the parish demographics. We're about 32% Black, 61.8% white, Native American 2.2, Asian 1.7, and other 2.3. In the study, because we were intentional, we enrolled 52% of the participants were African American, and 38% were white. And then you see the breakdown by ethnicity, again, Hispanic and non-Hispanic. And the prefer not to report was a big issue that we had, and we've had that all along during COVID. Male and female genders, as Dr. Lee reported nationwide, females participated 63%, males 37%, and the age group was pretty balanced. We did 25% almost, 18 to 49, 37%, 50 to 64, and then a large elderly population that wanted to be tested. If you remember early on, testing was very problematic and scarce, so they were very, very interested in getting tested. Next slide, please. And as I said, so when you look at retrospectively, in our Franklin clinic that operated the whole 5 weeks, we wound up having 409 participants. In our Morgan City clinic, we wound up doing 208 participants, and then the community participants were 401. So I think it was very well balanced, both on our patients in our system and outside our system. I cannot thank enough the folks from Centene for doing this. We had great partners in our mobile unit. We partnered with the Office of Public Health. They subcontracted with the National Guard. We had stations set up. Dr. Lee, I have to give her credit and kudos. She came up with putting the information on a tablet, which saved us tremendous amount of time and energy rather than using paper. So we had iPads and we had all the software categorized, separated, made life a whole lot easier to counter sign off on those. And then, so the patients came in, they got enrolled for the community test, and the National Guard did the swab. We had another station for the blood drawing, and it just worked really, really well. I can't say enough about the teamwork, both with the Office of Public Health, the National Guard, and Quest Diagnostics, which has been a tremendous partner. We were able to give the patients thermometers. We gave them pulse oximetries for those that were symptomatic and had respiratory component. And then later on, and I'll go over that in the Q&A, but I think my time will be up. But I can't say, of all the studies that we've done, this is one of the best ones that we've ever participated in. Our patients are very, very grateful. The community was very grateful to be a part of it. And then I'll save the rest of my comments for questions.
Dr. Wiltz, thank you so much for providing such an in-depth overview of what's going on in Louisiana. And we're definitely going to have follow-up questions for you. At the moment, though, I'd like to pivot to Dr. Sampson. Dr. Sampson, can you give us a similar overview of what's going on down in Florida at the Osceola Community Health Services, FQHC?
Sure. Absolutely. If I can share my screen here. Sure. So let me get to where I can start it.
Take your time. And just a reminder to the audience, remember, if you have questions, definitely drop them in the Q&A and we'll be sure to elevate them when that time comes.
I just need one thing for it to go play. There we go. So again, we are Osceola Community Health Services. I'm Dr. Marian Sampson. I'm Chief Medical Officer and the site Principal Investigator, and we are more than privileged to be a part of this study. I wanted to start off with our team. We are a small FQHC, have not been in existence very long, but this is our coronavirus team, and they were absolutely awesome, and you'll understand a little more as I go through the slides. So they were led by our quality management administrator, Sarah Salamo Bugs, who's a nurse and also Bachelor of Science in Nursing. So what is an FQHC? An FQHC is a federally qualified health center. That term was first used in 1989. It basically provides community-based healthcare, basic use from funds from HRSA, and that was a health center program overall. Providing primary care services in underserved areas is really our mantra. We also provide care on a sliding fee scale based on those patients' ability to pay. We do operate under a governing board that is comprised of at least 51% patients, people who actually partake in the care here. There are approximately 1,368 FQHCs nationwide, serving over 30 million patients annually. A little bit more history. They really began as neighborhood health centers. In the 1960s, the Johnson administration's War on Poverty opened centers specifically to serve the underprivileged. The first two centers were opened in 1965, one in Mount Bayou, Mississippi, which I'm a native of Mississippi, and the Delta Health Center, and these both are in existence today, and the Columbia Point in Boston, Massachusetts, which is Columbia Point Health Center. And for those of note, people who in the audience may be familiar with Meharry Medical College in Nashville, Tennessee, Mount Bayou's clinic was known for being one of the only clinics where Black doctors were allowed to train and intern. So we have been making steady progress. In 1975, the Public Health Service Act aligned the basic purposes of FQHCs to really provide a public safety net. In 1991, we were added as a very important Medicare benefit, and later we were added to Medicaid. In 1996, the Healthcare Consolidation Act really defined us as primary care centers for migrants, the homeless, public housing, primary health care programs as well. In 2002, the Healthcare Safety Net amendments more fine-tuned that we had obligations to patients regardless of their ability to pay. And in 2010, the Affordable Care Act delineated that we would be providing medical services to all residents in underserved areas. OCHS specifically, we have been in existence for about 3 years. In 2018, we became separated from the Florida Department of Health, and people still kind of get us mixed up because the address is only like 2 digits off. But we do provide behavioral health services, dental, family medicine, internal medicine, obstetrics and gynecology, and pediatrics. We have 6 sites, and that is to include our mobile dental unit, which is very active, and we now have a pharmacy that is coming on board. Our enrollment model, we were already in conjunction with the Florida Department of Health conducting COVID-19 testing. We were doing this 4 days a week already, so we just added in the study portion. 2 days a week, we started out with a 2-day preliminary rollout, and I think this was very important because it allowed us time to reevaluate our study model. It did greatly help to have the tablets, and some of the things that we did need were still on paper in terms of requisitions, and I'll elaborate more about that. But it was great to have that 2-day preliminary rollout just so we could come back and regroup and tighten things up. We had 2 clinic sites and 1 community site, which was a low-income housing site where we have a satellite clinic. We used totally outdoor tents, which in Florida, it was winter, basically, so that kind of made for different conditions depending on the day. We had a main line for patients to come in specifically for testing, and then they were offered enrollment, and then we split them off into a different line so that we could have the main study enrollees, and because that also included phlebotomy. We had to manage our own phlebotomy, and that was due to the Florida IRB restrictions. We were greatly appreciative of our rotating volunteers that came from our community partners, Centene and Quest. And it took us approximately 3 months to complete enrollment from about mid-November to late February. So by the numbers, we were able to enroll 1,007 participants at Site 1, which is what we call Stadium Place, where I work. 531 participants, and I'm proud to say that I'm one of those. At Site 2, we had 462 participants. And then at our low-income housing satellite site, we were only able to coordinate that for 1 day, but that worked out because we were still able to get 14 participants. 282 of these enrollees were already our existing patients, and we are administering COVID vaccines currently 2 days a week. And of our study participants, 654 have returned for vaccination. And that concludes my portion of the presentation. I will turn it back over.
Thank you, Dr. Sampson, and thank you, Dr. Wiltz. I think, especially given what the two of you have presented, it sets us up well for now what I imagine is going to be a pretty robust question and answer period. And again, I'll just remind audience members, please put your questions in the Q&A and your comments in the chat box. Questions below, comments to the side. I want to pivot and come back to Carl and to Dr. Lee here, and talk to you all really about the fact that this is a coordinated effort. This insight study is a coordinated effort across the country. You mentioned the various sites, and of course we have Dr. Wiltz here representing the site in Louisiana, and Dr. Sampson representing the site in in Florida. How is it, or what sort of challenges had you all anticipated that were especially specific to rural settings? What sort of considerations did you keep in mind? How do you overcome any challenges with respect to coordinating efforts across the country with respect to the study?
I definitely want to applaud the work of our FQHC partners for the rural settings. I definitely want to pivot that question over to Dr. Wiltz, because he was so innovative in utilizing the mobile units. And I think similar to what Dr. Webb said earlier this morning in terms of access, when you have a burning building, you don't expect the burning building to go to the water, you take the water to the burning building. And that's exactly what he did with his mobile units in going to where the people are. I think in terms of coordination, it's like they say, it takes a village to raise a child. And this study has been my child for the last, I guess, 8-9 months. And it really has taken a village from our FQHC site principal investigators, who you see two here on the line, to their staff leads who really led this effort. We met sometimes 2-3 times a week. I text them several times a day. There was no end of work hours. My mornings started early and my nights ended late. And I really think during this pandemic, it really took a sense of understanding the need and the urgency of now. We hear a lot from the community of needing information, understanding what this really means. And, you know, in terms of coordination, I think one of the things that really changed was when we saw that additional wave come at the end of last year. That's when a lot of the momentum picked back up, because I think there was a lot of complacency that had started taking place with, oh, we've been in this pandemic for months. Oh, I don't need to get testing. And it's just been, you know, some really interesting insights and things that we've learned for if and when we have another pandemic, or until we get out of this one.
Until we get out of this one, and when the next one comes, for sure. I think you're part on money with that. Carl, anything to add? And then we certainly want to bring Dr. Wiltz into the conversation.
Yeah, I mean, I think for us, I mean, obviously, I mean, I think Tasha's point about the kudos really go to Dr. Wiltz and, the local teams, really, and it's really, they're the ones that are on the ground sort of doing it. And I think as we were preparing for this too, Dr. Wiltz, remember, I think you had at least 2 to 3 hurricanes kind of come your way over the course of the summer too. So, they're kind of dealing with that in addition to us kind of helping them prep and get ready and everything else. And so just the very fact that he was able to pivot and, kind of like focus on his day job, just because he's still got a clinic to run, right, in addition to everything else. So, I mean, it's really testament to the great partners that we have on the ground. I mean, it really is. I mean, it wasn't easy in terms of identifying those partners in that, to be honest in that, but that's really the key, I think, that's one of the keys in terms of success. And I think we'll probably get to that point where we talk about best practices in that, but really Dr. Wiltz, Dr. Sampson, they've got great clinics, but also they've got great teams under them as well. And so, I mean, I was very, very impressed with that. I mean, you know, I'm not a clinician or anything else like that, but the very fact that they empowered their people to really to go out and make it happen. So I'll just stop right there. I mean, it was a great effort, I mean, on their part.
Well, to borrow a line from Kevin Hart, that's what we do. So I think that's part of our DNA and FQHCs. As far as hurricanes, we had a lot of experience with Katrina, and it's a part of life. So all of our clinics have backup generators. So we always anticipate the storm and then what we're going to do to get stood back up right after. So we never lose power. We're on the grid for getting stood back up after these natural events. As far as being intentional, so there was a question about that. We, as Carl said, and Dr. Lee, we have 250 people a day that come through our centers, because we have behavioral health, dental, we have 3 pharmacies, we have a lot of activity that goes on as a one-stop shop. So we knew we had people coming through our doors that would be willing participants. The community partnership was great because we do community events all the time. We have joint health fairs, so it wasn't a hard lift in that regard. And what we did, we had our mobile units set up right outside the recreational center. So the recreational center was like a big gym. So we had stations with people socially distanced and separated, and then stations within there for the swab, the intake, the swab, and then they went on the mobile unit to get their blood drawn. So it was all coordinated. And as I said, I think helping us in the beginning, and I neglected to mention that, we served 30,000 patients in those 7 parishes by focusing on St. Mary and making the demographics match up. And LaTasha and Carl knew this. We were meeting every week, twice a week. And when the numbers looked like we weren't getting enough representation from one group, we just continued to run our reports and say we need to outreach and focus on getting more Native Americans in, more patients in different zip codes. That was the other thing. We have a zip code process where we can do robocalls, and we instituted that. I know this is not the forum for it, but we use it during elections, actually. People do the robocalls, and we did it in this case for public health, and that worked out well too.
Well, public health and politics are not very far from one another. They are bedfellows in a lot of ways, right? Yeah, I want to bring you into this conversation here, Dr. Sampson, and focus on one of the things that Dr. Wiltz mentioned earlier. I too appreciated the fact that you said, Dr. Wiltz, you said several times in your presentation, because we are intentional, and the site in Louisiana has time and history and community relationship on its side. The site in Florida is newer, right? And so between the two of you, in terms of the time perspective, how have you been able to really overcome some of the trepidation that maybe a lot of people within the communities, especially those who have historically been marginalized and minoritized, how have you been able to overcome fear and trepidation in order to bring people into the study? So you've mentioned a little bit, Dr. Wiltz, but the intentionality between the trust building, what does that look like in a site that has had presence in the community for a while, and what does that look like in a newer site that's still burgeoning?
Well, as I said earlier, we had been talking about it, and Dr. Sampson alluded to something that was critical. Because testing was scarce, and our folks, you could see from the numbers of people that came in, but that actually set the table. We had those conversations, and we kept telling our patients that when the vaccines that were being developed, when we are confident that they are safe, we will be recommending it. And so we had, a year later, so when the vaccines became available, we had already built in the trust and had those preliminary conversations. And I noticed I think you said 680 or 654 of the people that tested took the vaccination, which is a great rate. So one thing begat another, and that trust carried over. Now we've done 7,000 plus vaccines, and the same model of scheduling is what we used. So this study just keeps giving, and it really was a great logistics. So, Dr. Sampson, I don't know if you want to comment.
Yeah.
I admire what she did, because it's taken us 47 years to develop this trust in our community, and she did it in a short period of time.
Yeah. So, you know, every conference call that we had with Dr. Wiltz and the whole Teche thing, I was like, I'm jealous, because we're starting out with like so little. However, it was still accomplishable. It was still a level of trust that we've started to gain within the community. This is our first study, you know, but of course we want it to be the first of many. So we have a great partner in Centene. We have great partners with Quest, NMQF, and now with the accessibility of information from Dr. Wiltz and his team, and how things can grow. You know, we are, again, just 3 years in. I think it helped a lot for staff, particularly the staff in different, because we have 6 sites. So for staff and administration to see us signing up for the study. I told them, I said, hey, I want to be in the study too. So just, you know, putting myself out there, and along with other members of my team, it gave the rest of the people around us the confidence to say, hey, you know, she's gonna do it. Well, I guess, you know, I'll think about it. We definitely put forth the additional healthcare proponents, which in terms of the additional lab testing, because, you know, everybody wants a lab test. Everybody wants to be tested for everything. And I'm like, no, you can't be tested for everything, but here's a set of tests that you can have, and you can have it, and it's going to definitely help us out in the future. So that was a big thing for an underserved community, because sometimes they don't have the time to come in for a full appointment, and they were coming through our tents for the most part. And we said, hey, you know, if you want to sign up, you can. That was one, I guess, a perceived barrier that we really thought was going to be an issue, is that we really could not say it was going to be a study until they were right in front of us. That was a part of the way that the IRB was written, is that you're not advertising. So the only advertising that was going on was for the testing itself, which we were already doing, but we offered them the study, but only once they were face to face. So having someone who looked like them offer them the test, someone who they already knew, like, hey, I come to this clinic, or I drop my friends off, oh, I know this lady, you know, and then having those same people also drawing your blood, going over consent forms, you know, going over them in Spanish. All of those things helped greatly, greatly, greatly to build the initial trust. And all you had to do was get 1 or 2 family members, and then you could get more. I wish we had the ability to specifically target more African Americans, but for our population, we have a high Hispanic population. So although I think our Hispanic rate was about 68%, and somewhere around 21 to 24% for African Americans, that's pretty standard across the board from what I see in my clinics. So yes, we had a time to build trust. Instead of 3 weeks, it took us 3 months. But we're okay with that, because we're the baby of the bunch. We're okay with following our big brothers.
Well, you all are
The other
taking
partners
big steps.
The other partners that we enlisted were the local elected officials, the faith community. That played a huge role when the mayors rolled up their sleeves, both to do the testing and then later for vaccination. So once again, it set the table, and I can't emphasize enough how much that meant for folks. And then having, you know, we don't have public transportation, but the consulate agent has a van, Community Action has a van. And so we're blessed to have Medicaid expansion in the state of Louisiana. Thank you, Governor John Bell Edwards and President Biden, President Obama actually. And then now, but that also helps tremendously, having transportation available to meet that need in a rural community.
You literally took the words right out of my mouth there, Dr. Wiltz. I wanted all of you to some extent comment on, these non-clinical issues with respect to gaining access, not just with respect to trust, but actually getting to where the elements of promotional wellness are. Yeah, so the transportation bit for sure. Dr. Sampson, I'm wondering, and there's a question from the audience about age demographics, where they're across the study participants. What were you seeing? And
I don't have those numbers immediately in front of me, but
anecdotally,
but it was a higher population of patients in the older age groups. However, I can recall signing off on several COVID tests. They weren't included in the study, but COVID tests as young as 4 and 5 years old. So it was affecting complete households because they were testing everybody in the car.
And so I ran quick numbers. I ran quick numbers for Osceola for that question that was posed in the Q&A. So they were kind of in the middle of that bell curve that I showed earlier by the gender and age. So they were primarily in the middle ages. But the interesting thing that I saw about Osceola compared to the other sites is multi-generational households. We saw individuals coming in, especially since Osceola in particular had large numbers of Hispanic Latinx populations, I think in part due to the fact that they were intentional in having so many of their staff being bilingual, and that helped to overcome that barrier. But we had, sometimes 3 generations of people coming in and testing in one household. And so that was an interesting phenomenon in particular I saw within that community.
And Dr. Lee, I'm recalling the one slide that you showed with the breakdown from an racial and ethnic standpoint, and then it was cases, hospitalizations, and deaths. And one of I think it was the first column that, or maybe the second, that demonstrated just close proximity within the household was certainly one of the elements that exacerbated each of those.
Exactly.
Right? And we know that, right? So certainly in that way, age would be a consideration.
Yeah, especially for multi-generational households, which tend to be in minority communities. While one person may be out in the workforce, the other members of the home being home, but yet they're not doing masks within the home, therefore the spread of the virus within that home. In one case, we had nearly a dozen people in a particular family. They all lived on the same block being diagnosed with COVID-19 in the course of the study.
That gets to the definition of homeless. We'll see in rural communities, we don't see people on the streets. It's just you'll see 12 people in one bedroom homes. So social distancing is impossible when someone got infected. Our demographics were higher for that 65 and older because historically that's we have a larger Medicare population than most FQHCs. I'm an internist, and so I started treating people when they were in their 30s, and now they're in their 60s and 70s. So
hey, Mia,
yes, please, Carl.
Yeah, I was going to add one other point too. And so while they're not on the call, our fellow center out in Los Angeles, we were talking about intentionality before, and so one of the attractions to JWCH was because they had one of their locations was like at a homeless shelter as well. So we were intentional in terms of trying to enroll different types of patient populations in the study. And I think while we were very obviously attracted to Dr. Wiltz and his focus on the rural community and all of that, Dr. Sampson, you get more of a city area, but Los Angeles, that was very important to us. The homeless, the fact that they were able to look at a portion of their population was homeless as well. So that is kind of like we were trying to, get a flavor for some different populations that historically, again, have not maybe been counted in that. Well, we don't have the data, or I don't have the data. It is something that we are looking at as well.
The beautiful thing, I think it was Dr. Wiltz who said it earlier, this will be a study that keeps on giving. And I imagine, Dr. Lee, and between all of you at NMQF and all of you at Centene there, Carl, you might want to, as you said, just continue the intentional point about, studying the impact on people experiencing homelessness and their, and their in the surrounding community. I certainly would look forward to those data for sure. So we have about 5 minutes or so left. There are at least two questions that I still want to elevate, and feel free for anyone on the panel to jump in here. You know, you have a number of sites for the Insight study, for this particular study. And I imagine that those sites will continue to grow. What elements, irrespective of location, do you imagine will be useful to replicate? What are some of the more successful components that you think we will be able to carry out across various sites?
As far as
really as far as just overall design of the study, or
let me just say this:
partnerships, use of technology.
If I had to draw blood, if you drew blood from me, it would come out FQHC. I mean, that's my blood type. Community health centers, the perfect partner for NIH and CDC and all partners if you want to study what is reflective of all America. And I have to give Carl and LaTasha, the way they did it, what he just explained, homeless population, urban, rural, African American intentionality. You want to do studies that are reflective of the people that are being treated, not one size fits all. And you can't get that broader experience unless you have clinical trials and research that involves the whole community. The old days of just white males being the targeted research group, I think are hopefully gone. And so I think that the more that people reach out to us, the more that they realize that, our patients want to be the beneficiaries of research, not this whole overcoming the stigma on vaccinations. And we all know about Tuskegee and the things that have done historically. We're being on the front line for trust, not only for medical services, but the social determinants of health. We deal with this on a day-to-day basis. And so we refer patients for, rental assistance, utility assistance, sign them up for Medicaid, SNAP, and we do all the things that are community-based, unemployment, register to vote. So it really, that richness that comes through community health centers just makes it a natural partner. So the model is there. And when I tell you the most, and I've shared this with Carl and the group, at the end of the study, a lot of our patients that tested positive for antibodies, we did a blood drive and targeted those that had convalescent serum. And to a person, not one turned us down. And you know what they all said? If I can help someone along the way, then I want to do it. And all the ones that we contacted donated freely their blood for convalescent serum. So I think we have a model that's ideal for further research.
And I will echo Dr. Wiltz. That was what was coming to my mind was the Framingham Heart Study. And that was a separate, carved out population that still is yielding and grooming physicians under, kind of some false lines. And the FQHC, just like we said, is a safety net. And safety nets tend to catch all of America. There's not one group that's going to be missed. There's not one group that doesn't use the resource. We take commercial insurance, and again, our board is comprised of actual patients. So we see the entire gamut, and utilizing that is important in terms of driving health policy. Driving health policy is going to come out of studies such as these for the future. So in terms of, just to echo Dr. Wiltz, it's going to be the thing that keeps giving. And if you can target it at the base level of a federally qualified health center, you're going to get that full swatch of America, and you're going to be able to service everyone appropriately in the future.
So Dr. Sampson referred to the Framingham Heart Study, and for those who aren't familiar with it or who haven't read it, I certainly do encourage you to look it up. It's it is the longest running epidemiological related studies for sure. And so in the last, I'm going to give you 2 minutes that we have, and I want to just do a round robin of final words or calls to action for our audience or takeaways with respect to this, and also to encourage people to stay abreast of what's going on with the study. I want to start with you, Dr. Lee, and then have Carl to jump in, and then go to Dr. Wiltz, and then Dr. Sampson, you'll close us out strong.
So we're working on a paper, and just a little teaser out there. I saw there was a question about how you can follow the study. So please do subscribe to NMQF's listserv. We will be publishing a website where you can follow the study. But one of the first papers that we're working on is really around vaccine hesitancy and or acceptance in our community. We saw in the media a lot of emphasis on vaccine hesitancy in communities of color. And as Dr. Wiltz, as well as Dr. Sampson indicated, that's not necessarily the case. And we want to shift that conversation. And our first paper will allude to the findings of this study and those perceptions, as well as those who've received vaccination at these clinics. So with that, I just want to say I really value our FQHC partners. And for those of you conducting research, I really do encourage you to reach out to the FQHCs in your area, because they can be amazing research partners. Thank you.
Yeah, and I would echo what Dr. Lee is saying too. I mean, for us, I mean, this was definitely a very worthwhile partnership and initiative in that. And having said that, though, it's not easy. I mean, the FQHCs, I mean, have they're doing great work, day in and day out in that. But, if I could lend one or two things to say, it's really in terms of actually doing it, that whole communication piece was so critical, I think, overall, over communicate, but really it is going back to that identifying the right partners. I mean, they are out there, and, this has definitely been, I think, a very worthwhile, effort in that to capture people that, quite frankly, a lot of folks don't necessarily think, are interested in that type of thing, but they are. And I think the F2HCs in this case, and the two that are here, and then the others that are still in the study, they're getting it done, at the end of the day. So I'll stop there. Thanks.
Well, I don't think you can get more granular than what we are. You can't get more local. I was in church yesterday, and, people know where you worship, they know where you shop, they know where I go run on a service road, they can put their hands on you and touch you. So I think that's one of the great benefits we have, as Dr. Sampson said, our local board. We serve 30 million people. I was blessed to be the chair of NAC a few years ago, and I want to shout out to Lathan Woodard. She's on the panel, I think, later on today or tomorrow. She's the current chair of NAC, the National Association of Community Health Centers. But the the National Minority, I think it says it all in your name. Quality form. It's all about high quality, increased access, increased cost, decreased cost of it, quality, and the joy of medicine. And as I said, I think this study is going to be one that is going to keep on giving some very important information. I think particularly on the genetic side is going to come to bear. And I look forward to continue to study with everyone.
Yeah, and not a lot to add to that, other than we were unique in being a very small and young FQHC. Partners believed in us. We believed in ourselves. We decided to, take on this endeavor because we knew it was worth our community. And I think that's all you can really do. When you're asked, answer the call. You have people out there who are willing to help you, believe in yourself, and it's always going to work out for the entire population, for the entire community, on a positive note in the end. And thank you for having me.
As long as there is intentionality, is what you've told us. I very much appreciate all that you all have brought today. Clearly, this conversation is a major demonstration of what can happen when you have private corporations, public organizations that are really driven by science, and have their ear to the ground with respect to politics, and an ear to the ground and workers on the ground who are doing the local work. So I very much thank Mr. Carl Garrett, again, who is the Senior Director of Government Relations at Centene Corporation. Say hello to all my friends over there, Carl. Dr. LaTasha Lee, of course, is the VP of Clinical and Social Research and Development here at NMQF. Dr. Marian Sampson, who is also a graduate of one of my alma maters. I appreciate you bringing your perspective as the Chief Medical Officer at Osceola Community Health Services. And of course, Dr. Gary Wiltz, who joined us all the way from Louisiana as the Chief Executive Officer at Teche Action Clinic. And once again, I'm Mia Keeys with the American Medical Association Center for Health Equity. To our audience members and your fabulous questions and chat comments, I thank you. I hope that you all remain hydrated, hope that your families are well. Continue to stick around for the rest of the summit. And for those of you who are coming tomorrow, I'm going to help to continue some conversations around vaccination. So thank you, and everyone be well. We'll be in touch with you all soon. Stay in touch with the study.
Thank you.
Thanks, everybody. Bye now.
Thank you.